I'm so excited to be here. Thank you so much for having me. I really appreciate it. So we'll do a brief about me and then we'll get into the presentation. I'm drinking coffee right now. I have a mimosa for when I'm done. I invite you to join me for brunch. It is Saturday morning, everyone. Let's enjoy it. All right, so let's get started. And I'm kind of an elder millennial, so technology is not really my strong suit. All right, so about me. Oops. So I did my undergrad. I have a Bachelor of Fine Arts in Photography from the University of Louisville in Kentucky. I was a super senior, so I went for a couple extra years. And you can see here that if you wanted to know what art school is like, this is what it is. And I did start med school with a mohawk, and it was the best haircut I ever had. So next up, I did med school at the University of Louisville. So I graduated in 2016. So here's a picture of me on my first day. I was so excited. And then there's a picture of me at graduation breastfeeding my first baby. Next up, I did my family medicine residency at Scott Air Force Base / St. Louis University. It was a combined military civilian program outside St. Louis from 2016 to 2019. So there's me in my first day of clinic year. And that's really how I felt every day. And then my last day of residency, you can see that it's kind of like, okay, I'm totally over this. That's me in the call room. There's the bunk bed behind me where I slept on my super long call, drinking a gigantic iced latte with more shots than should probably be medically allowed. Next up, we are at our first assignment at Grand Forks Air Force Base in North Dakota. So here is us last year and this year. So that's my husband, and I have 2 kids. My son is 4 and my daughter is 2. I was a HPSP scholarship recipient. I did kind of get deployed recently. And then as part of the troop drawdown in Afghanistan, my clinic was closed, and so I was sent home early. And I think, is there more? Let's find out. Nope. Okay. All right. So I think that's it. So now what we're going to do is get started in talking about LGBTQ medicine. All right. So why does this matter, right? You know, people kind of are like, oh, why do we have to talk about LGBTQ medicine? Like, I don't understand. So the United States Transgender Survey showed that 1/3 of our transgender and gender nonconforming patients reported adverse encounters with a healthcare provider related to their gender. And many reported straight up being flat out refused care. This is a slightly older survey. When I was in med school, I was lucky enough to be participate in a transgender survey of Kentucky trans people. And the stories were heartbreaking. And that was in 2017, 2018. No, sorry, 2015, 2016. And also blur. So this is not new. And in the trans patients I've talked to up here in North Dakota, many of them have also been refused care. So a 2002 study showed that half of our LGBTQ patients do not disclose their sexual orientation or gender identity to their doctor. Sometimes it's because it's not necessarily relevant. However, it's a good thing for physicians to know so that they can provide the correct care to patients. Also, 2011, 1/3 of US medical schools have 0 hours of LGBT training in the clinical or preclinical years. The median was 5 hours. This is somewhat better. The AAMC actually has a list of, I think it's 48 LGBT objectives that need to be in each medical school's curriculum. It's not mandatory, however, for licensing. So a lot of med schools do not have this in these learning objectives in their curriculum. 52% of academic medical centers in 2015 had no LGBTQ competency training for faculty. So how are we going to teach our up and coming medical students and the future doctors how to care for this population if the faculty aren't even trained or comfortable with it themselves? And then 4,000 first-year medical students found at least 80% had some degree of implicit bias against sexual minority patients, and almost 50% had some degree of explicit bias. We do not live in an LGBT-friendly culture here in the United States. It's getting better in a lot of ways, but those old things die hard and they don't go away without a fight. So just to introduce this, just in case anyone isn't familiar with it, this is a really cool way that I think of kind of describing how gender identity, gender expression, biological sex, and attraction are all different. right? So, and they all exist on a spectrum, and that spectrum can change throughout a person's life. Your gender identity, expression, and attraction is not fixed, right? And we also know that biological sex isn't necessarily binary either, correct? So this way you can show that you can exist on many different parts of the spectrum and still be you, okay? So we're just going to do a brief history lesson because, again, a lot of people don't think this is relevant for them. So for most of American history, we have the sodomy laws, which basically made homosexual sex between consenting adults a punishable crime. In 1948 to 1956, the Kinsey reports rocked our worlds because they're like, hey, everybody's a little bit gay. And 1950s in America is like, clutching their pearls. 1953, Eisenhower signed an executive order banning homosexuals from federal employment. Many state and local governments followed suit, and there's some question of if this is a response to the Kinsey reports. 1962, Illinois becomes the first state to legally allow homosexual sex between consenting adults. So if you think about your parents or grandparents, most of us have people in our family who were alive in the 60s, and so that's when the first state in the 50 United States allowed people to have sex between consenting adults. Think about that, okay? 1969, Stonewall Riots ignites the LGBTQ rights movement, and just for everyone's clarification, LGBT rights are because of people of color and trans people, okay? 1973, the American Psychological Association removed homosexuality as a disorder from the DSM. Whose parents were alive in the 70s? Okay, yeah. 1975, Civil Services reverses a ban on employment of homosexuals. Minneapolis adds gender identity to its non-discrimination laws. So for, again, very recently, if your job found out that you were gay, you weren't allowed to be hired, okay? 1981, the first AIDS case hit the press, previously called GRID, gay-related immune deficiency syndrome, which is obviously a terrible name. 1987, AZT, the first antiretroviral drug, becomes available. In those intervening years, AIDS destroyed a whole generation of LGBT people. So in your lifetime, who here was alive in 1990? I can't actually see you, but I'm assuming you're raising your hands. So in 1990, the US reversed a ban on immigration of gays and lesbians. So up until 1990, if you were a gay person or a lesbian, you could not immigrate to the United States. 1993, Don't Ask, Don't Tell becomes law. So this is basically for the United Military. If you're gay, you can be in the military as long as no one finds out, which is awful. 1999, American Counseling Association, and eventually all major psych organizations officially opposed gay conversion therapy. 2000, Vermont is the first state to recognize same-sex civil unions, not marriage. Who was alive in 2000? Okay. 2003, the United States Supreme Court rules that sodomy laws are unconstitutional. This was 17 years ago, you guys. So up until 17 years ago, if a state wanted to, they could prosecute a gay person for having homosexual sex legally. That's insane. So 2004, Massachusetts became the first state to recognize same-sex marriage. 2010, Don't Ask, Don't Tell is repealed. LGBTQ members are allowed to openly serve in the US military. 2015, the Supreme Court rules that same-sex marriage is legal in all 50 states. And then in 2019, just last year, gender identity, sexual identity, and sexual orientation were added to discrimination stuff. So up until last year, your employer could still fire you if they found out you were gay, and it was completely legal. So back to that. So what is the LGBT community at risk for at large? So a lot of this stems from the fact that LGBTQ folks as a community are at higher risk for being underinsured, underemployed, having chronic stress from living in a society that is homophobic. So higher cholesterol, high blood pressure, anxiety, depression, PTSD, decreased screening for cervical, breast, and colorectal cancer. Again, that's because if you have terrible experiences with physicians, you're not going to come for your preventative care, right? Tobacco use, drug and alcohol use, STIs including HIV/AIDS, homelessness, underemployment, uninsured status, intimate partner violence, and homicide, suicide victims. trans women of color are significantly higher to be murdered than literally any other population. It's insane. So a lot of Americans are very uncomfortable talking about sex. We sort of have this idea that you want to have sex because it's awesome, right? But you're also kind of dirty and ashamed that you want it. You shouldn't be dirty and ashamed. Sex is totally awesome if you are interested in having sex, because asexual people, I hear you, I see you. So how do you take a sexual history if you're interviewing someone in a clinic, let's say? So the CDC suggests using the 5 Ps, and I like this because I am simple and it helps me remember things. So the first up is partners. And you want to make sure you ask this in just sort of a broad way, so that way people can answer and they don't feel judged or intimidated, right? So are you sexually active? With whom? I say, are you sexually active with men, women, or both? Like, it's not even a thing, like it's just kind of on my checklist, right? Things are only as weird as you make them. So how many partners have you had in the past 12 months? And what this does is it helps you risk stratify someone. Practices. So in the past 6 months, what types of sex have you had? Are you having genital sex, anal sex, oral sex? Next up is protection for STDs or STIs. What type of protection do you use and how often do you use it, right? So people will say, oh yeah, I use condoms. And I'm like, that's awesome. Are you using them every time? Because I know sometimes it's hard to remember. And most of the time they'll be like, yeah, not every time. And then we talk about it. Past history of STDs. Have you ever been diagnosed with an STD? How were you treated? Are you having any symptoms right now? When was your last HIV test? And again, knowing what type of partners a person has and what type of sex they're having helps you risk stratify them for STDs. STDs aren't just in your pants, right? HPV is the leading cause of throat and mouth cancer. You can get chlamydia and gonorrhea in your mouth. You can get herpes in your mouth. It hurts. So that's why it's important to know what type of sex a person is having. And then lastly, prevention of pregnancy. Are you trying to become pregnant or have a child? What are your fertility goals? This is a really good way of asking about birth control use without assuming that someone is having heterosexual sex, right? What are your fertility goals? Next up is transgender medicine. So this is the actual best thing. It's the UCSF guidelines. You can just type in the Google machine, UCSF transgender guidelines, and literally for every single thing you could possibly want to know, it'll tell you what to do. A lot of primary care doctors are very uncomfortable with transgender medicine. They think we have to refer to an endocrinologist or specialist. The problem is that in a lot of areas where people live, access to those specialists is months out, or someone who doesn't have insurance, or the specialist doesn't take their insurance. Transgender medicine is not any harder than managing diabetes or thyroid medicine. It's cookbook medicine. You say, here's the labs I need and the values I want, here's the medications, and then you titrate them so that way they line up. It's really not difficult. So what we can do to fix this is to help increase education for primary care doctors, so that way primary care doctors can manage the majority of uncomplicated transgender medicine cases. Of course, there are always people who will need a higher level of care, but in general, you can at least start someone on meds, get them monitored, get them going, so that way by the time they're able to get into a specialist, if they need one, they're already receiving that gender-affirming care, because gender-affirming care is life-saving for our trans patients. And so what can you do to let people know that you're an ally, right? I'm a cisgendered, heterosexual white lady, okay? So let LGBT patients know that they're welcome there. Use inclusive language on your intake forms. Don't have male or female for gender, right? You can just say, what is your gender? And let people write it. That's a great way to, if you're in an area that's really anti-LGBT, be an ally without being like, about it, because for some areas you'll get a lot of pushback if you say, I want to, include other genders on our intake forms. Ensure your clinic pictures include non-heteronormative families. Is there a picture of 2 women with 2 kids? Are there pictures of 2 men, right? Are there pictures of transgender people? Have some indication you're an ally. Maybe a rainbow flag sticker near check-in desk, maybe a pin on your white coat, and have gender-neutral restrooms. Again, the gender issue or the restroom issue is really, really hard for our trans and non-binary patients. A transgender person does not have to look cisgendered to be any less valid, right? Again, it's a spectrum. So a trans woman doesn't have to look like me to be a trans woman, right? Do not assume heteronormativity. You know, ask if the patient has a partner instead of assuming a husband or a wife. And even the most well-meaning allies can mess up. I actually messed up with this recently. I was talking to another physician in the military, and you know, we were just chatting. I was talking about my family. I was like, "So what does your wife do?" And he's like, "I don't have a wife." And then I was like, "Ugh, I'm so sorry for my heteronormative assumption." And he laughed, and I was like, "No," he's like, "It's fine." I'm like, "No, it's not fine. I'm really sorry." And then you just move on. You don't want to belabor the point. Ask and use someone's name and pronouns. So this isn't necessarily preferred pronouns because that makes it sound like a choice. It's what is their name and their pronouns, right? If you see someone's baby and you're like, "Oh, he's so cute," and the mom says, "Oh, she's a girl," you don't go like, "Oh, well, blah, blah, blah." You say, "Oh, sorry about that," and just keep using the correct pronouns. Same thing. If you meet someone new and they're like, "Hi, you know, I'm Michael, but I prefer to go by Mike," you wouldn't call them Michael. You would call them Mike because that's what they go by. So normalize it by introducing yourself and your pronouns. "I'm Dr. Snow, my pronouns are she, her." Communicate this to staff for future encounters in case the patient's name and gender doesn't match their chart and their pronoun. I know in the military medical system, changing someone's name and gender in our medical chart is a huge pain in the ass. So we have, my base is pretty small, so we don't have a ton of transgender patients. So everyone's pretty familiar with them. So that way we know if we see this person, we know the correct name and pronouns to use. And then treat gender or sexual orientation as disclosure as routine when taking a sexual history. Again, if you make it not a big deal, the patient will feel much more comfortable because they'll feel like they're not having some big reveal to you. And then use gender neutral or anatomic language. So use the word pelvic exam versus vaginal exam, use chest exam versus breast exam, stuff like that. Don't be that person. So don't misgender or dead name someone. And everybody messes up. If you do, apologize and move on. A couple of my friends from undergrad have come out that they're trans or non-binary and prefer to use different names and pronouns than when we first met. And these are people I've been friends with for like 10, 12 years. So it's a little bit hard sometimes to switch. So what you can do is you can practice it, you know, like before you see them, you sit and you go like, "Alex, they them, Alex, they them, Alex, they them." And then make sure that you use it intentionally in a sentence to help yourself get used to using it. And if you hear someone else misgender someone, just gently correct them. Just say, "Oh, hey, you know, so-and-so uses he, her pronouns. So-and-so's name is actually this," especially if the patient isn't there. The true test of your character is what you do when no one is watching. So how do you act when the trans and non-binary people are not there? Don't exotify. So they're already in a vulnerable position in that power dynamic between patients and physicians because they need something from you. And in their experience, there's a 50% chance you won't give it to them. So you don't want to act like they're this like exotic thing, you know, just treat them like a person. That's all they want to be treated like. Don't ask irrelevant or nosy questions. Don't ask about childhood experiences or surgeries or private parts. If someone who is trans is coming in for a sore throat, just examine them like they're a person with a sore throat because that's what they are. They're just a person with a sore throat who happens to also be trans. Don't assume somebody wants hormones or surgery. Again, this goes back to everybody's journey is different, and we shouldn't assume that all trans patients want to have surgeries or want to completely switch their appearance to be with whatever your idea of what a man or a woman looks like, okay? And don't rely on our LGBTQ patients to teach you about LGBTQ health. That's not their job, okay? There's so many resources out there. You have the internet in your pocket. Use the Google machine, use resources. Find somebody who knows what the hell they're talking about and ask them to teach you, okay? So many times I've had trans patients tell me that they had to tell their doctors what labs they need, or they had to tell their doctor what meds they need. And that shouldn't be their job, right? All right, and is that the end? Oh, shoot. So here are my sources. There's a lot of them. Okay, any questions that I can answer for you guys?
First of all, thank you so much. This was an absolutely amazing presentation. Everyone in the chat is just loving it, and thanking you for bringing awareness to this topic and openly talking about it. But there were lots of questions, and so we'll try to get through the ones that we can. And so there was a really important question that I think a lot of people had, and Maddie asked, how do you think that we need to change as a medical community to build trust within the LGBTQ+ community besides, of course, actually helping everyone without bias?
Right. So a lot of it is confronting your internal biases. And so, if you tell somebody that they're homophobic, they're going to get their feelings hurt because homophobic people are bad people and I'm a good person. No, we all exist in a homophobic culture and that stuff is baked in. This is especially true for me in the military when I have to bring this up where people are like, I treat everyone the same, blah, blah, blah. No, you don't. So you have to help people be open, again, just to recognizing those implicit and explicit biases. And then a lot of it is just education because people are uncomfortable with what they don't know. And again, because we do a really shitty job of educating med students on how to provide good care to LGBT patients, they don't feel equipped when they get into the real world and encounter these patients.
Great, thank you for that answer. There's also a really interesting question, and I guess this is just kind of what your opinion is, but do you think that we should mention our sexuality and our pronouns during a med school interview or in applications for fear that people might not look down upon that?
It really depends on whatever you're comfortable with. I am trying to normalizing introducing my pronouns. So actually on my email signature for my official military email, it says my rank, I'm Captain Lindsay Snow, MD. I'm a physician in this group. Here's my phone number. And then at the bottom it says, ma'am, she, her. And that has led to a lot of really good conversations with people who otherwise may have never asked about it. And again, I'm in that position because I'm a cis hetero lady, so I have all the emotional bandwidth to talk about this. If you don't have the emotional bandwidth or you don't feel safe disclosing that part of yourself in an interview, that's okay.
Yeah, that's awesome. Thank you for kind of helping us realize that we need to normalize that. Kind of going off of that, you did mention like your signature is ma'am, and someone was kind of asking when you're talking about like the patient form and like just putting gender and kind of leaving it open, kind of how would that work for titles, like for Mr. or Miss or something, or should that just like really not be something that's like part of a form anymore,
Right.
that title?
So you can ask. That's never a wrong thing, is just to say, what would you prefer that I call you? How would you prefer to be addressed? Or what can I address you as? I go by doctor because I worked really hard for that. In the military, it's a little easier because we do have rank and last name, so you can kind of cheat a little bit. But, if somebody says, non-binary, there's, I always struggle with the pronunciation, but it's written like MX for people who may not identify as a Mr. or Miss. So just ask, because that shows that you care.
Yeah, absolutely. That's very true. There's tons of questions asking about just like how and why you decided to join the military and why Air Force. And I know you've been excited to talk about that.
Sure. So I joined the military because I was terrified of debt. Looking at $250,000 worth of debt was a really big number. I got very lucky in that I had an academic scholarship that paid for my tuition for undergrad, so I didn't have any undergrad debt. I still worked to support myself because, my parents just weren't able to support me. So, I always worked 2 jobs in undergrad. And it was really intimidating to think about having to ask for so much. Sorry, my cat's trying to knock over my coffee cup. Could you not stop? And so I did that. I had a friend whose husband was in the military and it seemed fun. I dated a guy who was in the Air Force, and the Air Force seemed nicer. They had a lower rate of sexual assault than the Navy and the Army. And I'm like a small person, so that's always something that I worry about. So yeah, that's why I joined.
Great, thank you for sharing your personal experiences. Back to, there's a question asking about how do you deal with homophobic or transphobic parents whose children identify as LGBTQ during clinic visits, and how do you navigate both your patient and then their families?
Right. So a big thing for that is one of my residency colleagues actually encountered this recently. She got an email from a parent saying, do not address my child as their name. they are whatever their birth name was, and they are whatever their birth gender was. It was basically saying that this kid saying that they were trans was a sickness. And so the thing for that is, luckily in the military, we do have a lot of resources. So you're able to say, like, you have to go to counseling. In the military, people kind of lose some of their rights. So if someone in the medical group is like, this person needs counseling, they have to go, especially if they're active duty. It's a little wishy-washy with people who are not active duty, but they're still kind of under some more rules than people who are not active duty or in the military. So recommend counseling, and then a lot of it is trying to get that kid or adolescent alone, and then just validate them. Just say, like, it sounds like you're having a really hard time at home. I just want you to know that I'm here for you. And just knowing that they have somebody who believes in them and trusts them and doesn't think that there's anything wrong with them can be life-saving, because LGBT kids have a 50% higher rate of suicide or attempts at suicide than heterosexual peers. So just having one person in the home who validates them and loves them for who they are can be life-saving. And so I've had that conversation with parents before, and sometimes, it depends on your rapport with the parents. So if I have a really good rapport with a family, sometimes I can be a little brutally honest. I'm like, look, these are the rates of suicide for LGBT youth, and the choice is yours. Do you want a dead child or a gay child? Do you want a child that's in your life when they leave the home, or do you want a child that you don't speak to anymore? It's up to you. And sometimes kind of laying it out in those terms can really sort of crystallize the issue for them. And it's also okay to validate for parents that there can be some mourning with this process. These people, and I'm a parent myself, so, like, I have a little boy and a little girl. So if at some point I have two girls or two boys, or a kid one of my kids is non-binary or something like that, there can be that mourning where you're like, I gave you this name, I chose you this name, you've always been this, and like, it feels like a rejection of you in some ways, but that's for the parent to process. That's not for the kid to process. And so that's why some really intensive counseling is important.
That's great insight. Thank you so much for that response. A lot of people are saying that you should definitely teach sexual health in high school or middle school. You're amazing. So we completely agree with that as well. There was a question asking about, are there, if any, what kind of professional opportunities are available to physicians to talk about these topics and to learn about how to be more inclusive? Are there, like, conferences, trainings, or is it just something that you need to seek out yourself as a physician?
So more organizations are starting to require LGBT competency, but it's more in the flavor of the computer-based training where you sit, you click through the things, and then you take the quiz that you didn't really pay attention, and congratulations, you're competent. No. So some organizations are doing more intensive workshops. This was obviously easier in the before time when you could gather multiple people with no mask. There are conferences, a lot. I know AFP, the American Academy of Family Physicians, often in their huge national conference will have like an LGBT competency. There are training courses. So if you want to become, like, feel more comfortable with transgender medicine and hormone prescribing, you can take little courses. So that way you get a little bit more intensive training and you can feel more comfortable with it. So unfortunately, at this juncture, a lot of it is things that people have to seek out for themselves, but the resources are there. There's tons of resources. You just have to do it.
Yeah, absolutely. So we had a question that says, have you had encounters with a member of the LGBTQ community from, like, different cultural backgrounds? Because, some are a little bit more, I'm Persian, I can say this, a little bit more harsh, just like with their upbringing, and definitely being, like, from, like, a brown family. And, like, how have you dealt with that, if you have?
So I have not particularly dealt with a ton of that, again, because I mostly practice in the military community. So it's sort of not really representational of the population at large. But I have practiced with a lot of deeply conservative religious people. So that might be a little similar. And a lot of that is really everyone just needs therapy. One of my good friends is a psychiatrist, and she's like, you get therapy, you get therapy, you get therapy. So helping people process those feelings, and again, a lot of it is just validating and listening. They don't need to know my opinions, again, as a cis hetero white lady. What they need is for me to listen, validate, and then help them find resources.
Yeah, that's absolutely true. So kind of shifting gears a little bit, this kind of goes more into the family medicine, but you did mention like having to like refer like transgender patients to endocrinologists. Is that something that's more like a partnership? Like, you know, you do need to like go to an endocrinologist for like hormone treatment, or is that something that you can do yourself, like work with that process?
So it's completely within the scope of practice for family medicine, internal medicine physicians to initiate hormone therapy and manage it as long as the patient responds well and their labs aren't crazy. If you get a trans patient with a lot of other comorbidities, it's not wrong to kind of call in for help and just say, hey, you know, I've got this kind of complicated patient. Let's manage this person together. Try to have as much of a collaborative relationship as possible. You know, I try to be a little bit obnoxious and like get all my patients' notes and follow up with my trans patients. But again, I kind of have that privilege because there's only a handful of them and I work in a different system. So yeah, so it's totally within our scope of practice. Again, it's cookbook medicine. You get someone's labs at these intervals. You start these medications generally at this level. Here's kind of how you can titrate it up or down. And then you can go from there. You know, if the patient's responding well, if their labs look beautiful and they're not having any crazy side effects and they're doing great on the meds, they may or may not need a specialist.
Going off of that, there were a lot of questions asking, as a family medicine physician, how often do you work with physicians from other specialties, like consults? How often do you send your patients out? Is that something that you do just on a regular basis?
Yeah, pretty frequently. You know, I try to practice to the upper limit of my scope. And again, every family medicine, every physician is different. Some people refer more frequently, some people don't. And again, it's just what you're comfortable with, what your access is. I'm lucky we have pretty decent access up here. I'm in the military, so it's like having monopoly money. Like if I say, oh, you need to see a specialist, they just go see the specialist. But again, not everybody has that privilege in our current healthcare system.
Thank you. There's a question, I just lost it. They were asking about, so when you're talking about exotifying patients, there's a question asking when their chief complaint is centered on some noting of a past genital surgical history. Do you have any advice on how to have those conversations without kind of bringing out that past that can be kind of traumatic to some people, if it's like part of the reason that they're there to see you?
Right. So again, a lot of it is just sort of your approach. If you're nonchalant and act like it's no big deal and just be like, okay, so, you know, you're here for this, help me understand sort of the background behind it. And then just let them tell their story, ask questions where it's relevant, but really just stick with what is clinically relevant. So, you know, if somebody, let's say, who has like a penile prosthesis and has an implant to help that person achieve erections, is having some post-op complication, just stick with asking about the surgery. You know, is there redness? Is there swelling? Is there drainage around the incision? When did you see your surgeon? Did they give you antibiotics? Are you having these symptoms? You don't necessarily need to delve into, you know, did they have top surgery? I hope that answers the question.
Yeah, absolutely. Definitely stay relevant. Kind of shifting gears, there's a lot of people that just wanted to know like why you chose family medicine, if there was any other specialties that you ever considered.
Yeah, so when I started med school, I wanted to do emergency medicine. Like I was like EM all the way. I don't want to see these people. I want to be all exciting. Give me all the trauma and the blood and the gore. And then I discovered that actually I really like talking to people and I like forming those longitudinal relationships. And I have super bad ADHD, so I get distracted really easily. And so being in a slightly slower paced environment where I can stop and think is helpful.
Awesome. Thank you so much for sharing that. Again, I'm so sorry. I don't know why I keep doing this. So in regards to the military, what are some pros and cons of doing a military residency versus a civilian one?
Sure. So a lot of it comes down to what are your goals? So in the military, in the civilian world, you have a significant more control over where you apply, what specialties you apply to, where you live, what kind of practice environment. And if you're a civilian and you hate your job, you can leave. In the military, if you don't like where you live and your command is awful, you're stuck for 2 to 4 years. And that can be a long time if you're stuck in a really toxic environment. I'm super lucky. My current command and all the people who I work with are super awesome, and I want them to stay forever, but I know they won't. So I'm super lucky in that regard. Another thing would be is if you're dead set on maybe more subspecialty or something that is not what we in the military call deployable. So for better or for worse, the goal of the military is to fight bad guys. So if you're a sort of doctor that can't deploy and support troops in a combat environment, you may or may not be, those specialties are being, at this time, reduced, right? So if there used to be, let's just say 50 pediatric ENTs in the military, you can't deploy a pediatric ENT, right? Because they did a peds residency. They're not trained to treat adults. Maybe not ENT, let's just say pediatrician. They can't treat adults. So now instead of 50 spots, maybe now there's 30, because they still want to have some pediatricians to support the military families, but they need more spots for people who can deploy. So if you're dead set on a specialty, I wouldn't recommend the military at this time because there's no guarantee you'll get it. There's a limited number of spots per year, and it goes by rank. So you get so many points for prior service. So let's say you did 4 years as an enlisted person before the military, before med school. You get so many points for your board scores and any research and presentations, and you get so many points for your audition rotations and if they just like you. And then they rank people. So let's say that there are 30 emergency medicine spots and you're number 32. You don't get to do emergency medicine that year at least. You'll have to go do an intern year. And then if you don't match again, you have to do what's called a general medical officer tour, where you provide primary care to certain squadrons and bases, but you're not doing whatever specialty you want. This situation happened to, and you can actually also, even if you match, they can take it away. One of the flight docs at my base matched orthopedic surgery, civilian. He was so excited. And then he got a call that the military was actually not having that spot anymore, and now he had to go do flight medicine. So for surgeon types to be stuck in primary care, that's their personal hell, which I get it. Like if I was stuck in OR, I would hate it as well. And everybody's different, and that's okay. Like I'm not mad that he hates primary care. So that's something that you have to be okay with. The other flight doc that we have wanted to do emergency medicine, but she didn't make the military match, so she doesn't get to be an emergency medicine doctor for 2 to 4 years. So if you're okay with that kind of uncertainty, that's fine. But if you're dead set on a specialty, if you don't want to risk delaying your training, if you want to stay where you have family, don't join the military, because you will have no control over pretty much any aspect of your life.
Great. Thank you so much for sharing that. We appreciate it. We had a question that's was just saying, like, we know you mentioned that, not to outright call someone homophobic or transphobic because, defensive, but have you ever had to address any anti-LGBTQ plus attitudes or behaviors with colleagues? And if you have, how have you managed that conversation?
Sure. So a lot of it is just kind of, and again, I have a significant amount of privilege because I'm an officer, I'm a physician, right? So I'm in a certain place where I can say things that not everybody may or may not feel comfortable saying. Also, they can't fire me, they could fire me, but it'd be really hard to fire me. So that gives me a little more significant leeway than some other people may feel that they have. And that's also okay, right? Because your safety and your personal stuff is the number one thing. So, for example, we have a trans patient who comes in for testosterone injections every 2 weeks. And in the chart, his gender is incorrect. And so we have two of my, medical technicians were talking about, like making sure they get the medicine and all that for him, but they kept misgendering him. And so I was just like, hey, friendly reminder, their pronouns are he, his. Just let's make sure we use that in the chart and when we talk about this patient, because we want to validate his personhood. And if you're just sort of really gentle about it, and again, try to make it not a big deal so that way the people are more receptive, then usually people go with it.
Thank you for answering that question for us. A lot of people are really thankful for your openness and your honesty and how you go about it.
And also these views are just mine. They're not the views of the United States military or Air Force. Military physician will have different opinions, and that's okay. So my word is not necessarily the gospel. It's just my experience in the military, in my opinion.
Thank you. Sorry, we keep bouncing back from topics, but there's just questions keep coming in. Kind of going back now to your military, there is several people wondering, once you go into military medicine, so you did the HPSP, I think that's the acronym.
It's the Health Professions Scholarship Program.
Okay, so yeah, HPSP. So how long is how long do you have to serve? Is there a 1-to-1 ratio, 1-to-2? If you could kind of talk about how obligated you are to stay in the military.
Yeah. So the military paid for all 4 years of my med school. So then they told me where to do residency. I wanted to do a civilian residency. I had a civilian institution that was like, we love you. And I'm like, I love you too. And then the military was like, nope, you have to go here. So I was lucky in that I got my second choice.
Подожди, мы сейчас вот так возьмем колясочку.
Sorry, hold on. Let me. Okay.
So when I signed up, and again, the HPSP scholarship does change, and the match process does change a little bit every year, but that's the general idea right now. It could change. I don't know if it's 1-for-2 right now. There was some talk of that happening, but for me, it was 1-for-1. So so they paid for 4 years of medical school, and I owed 4 years post-residency. If you do a fellowship or anything like that, that can add time to your commitment.
Okay, and then going off of that, after you are done with your 4-year commitment, are you free to leave the military and go into civilian practice if you were to choose to do so? Or can you stay in the military for 20, 30 years? Okay.
Yeah. So, and the military has different tracks depending on what you're interested in. So there's the clinical track for people who just want to see patients. And in the military, you automatically promote up to lieutenant colonel. So it goes lieutenant, captain, major, lieutenant colonel, colonel, and then you get your generals. So up until lieutenant colonel, you automatically promote. Once you reach the colonel level, you start having to do things. I don't know what they are because I'm never going to do it. But once you reach the end of your commitment, which mine is July 8th, 2023, now that I'm counting, you can decide to separate or stay in.
Okay, and so that was really good. Some people were wondering about that time commitment, so thank you for clarifying that for us.
And again, it's constantly changing. So yeah. HPSP, I did it in I commissioned in 2012. So that was 8 years ago. So, whatever, it may be different now.
Yeah, I had heard some 1-to-2 ratio talk as well. So I guess it just changes as time goes. There's a question asking if there's a difference, or if you think there's a difference in the types of patients that you'll see in military, I guess more specifically Air Force medicine, than the civilian world, or if they're just similar in general.
Oh, totally different. I only see active duty patients. So I only see healthy 18 to 45, 50-year-olds, right? And then also for military, even if you're not seeing active duty, you're seeing patients with access, right? And that makes a huge difference. Military people in general have in some ways better health outcomes because they have that access, right? They don't have copays to go see their primary care doctor. If they get their medicines on base, they don't have to pay for their meds. A lot of times specialists, it's a very small copay if there's a copay at all. You know, tests, all that is significantly easier to access than people who even have really good civilian insurance. And then also, you know, because I only see active duty, that filters out a lot of chronic medical conditions or even general conditions that you might see in the civilian world. Because if you get diagnosed with certain conditions, you can't stay in the military anymore.
Great. Thank you so much for sharing that. There's a ton of people that are just really curious about your work-life balance and managing your family and medicine and all that.
Yeah, so I met my husband during my first semester of med school, and we got married right at the beginning of third year. And then we had our first kid, my son, at the end of med school. And then we had my daughter during my second year of residency. So being pregnant during fourth year was super awesome. Having a little baby during intern year fucking sucked. It was awful. And then being pregnant during second year was great, and having a little baby during third year when I'm gearing up to graduate and move was also really, really hard. So for like the past 4 years, probably, and my husband's a stay-at-home dad just because with my work schedule with residency, paying for daycare, we basically, all of his salary would have gone to paying for daycare, and it would have been a lot harder for our family to manage. And again, that's not an option or a good choice for everyone, but it was a good choice for us. As far as balance, it's not really balance. I think the idea of work-life balance is bogus, and it just makes people feel bad. It's more of you're juggling and you're gonna drop a ball, and it's just deciding which ball to drop. I can't remember who it was who made the analogy, but some of the balls are plastic and some of the balls are glass. And you have to know which ball, if it's a glass or a plastic ball, right? And at some point you're gonna feel overwhelmed. At some point you're gonna miss commitments. And again, everybody's career trajectory is different. It depends on the support you have, right? So we have never had, because of the military, we've never had family nearby. So if we wanted any babysitter or any help, we had to pay for it. Whereas people who are fortunate enough to have family support have a significantly different parenthood experience than what I have. And it may make kind of a work-life balance a little easier having that support. For me, I try not to work when my kids are awake because I want to be present for them. And so because of that, I was not an amazing resident. I'll just go ahead and say that. Not great. I passed. I was an okay doctor. I was an okay resident, but I wasn't stellar in any way, shape, or form because I had these two little kids and I was just trying to survive. You know, there's also mental health stuff. I had really, really bad postpartum depression and anxiety. And so getting to a point where I really needed help and was finally like, okay, I need help, because asking for help is super hard, especially for people who are like really high performing, stuff like that. You're like, something's wrong with me that I need help. No, it's that our system sucks, number one, because residency is inhumane in a lot of ways. And it's okay to ask for help, right? Everybody's brain is different. Everyone has different neurochemicals. And if you don't make your own neurotransmitters, then store-bought is fine, right? So, you know, I'm still learning how to balance. You know, I'm still working on having me time and stuff like that. Still working on my marriage. You know, my husband is the most amazing person, and I'm so lucky that he puts up with me. So it's kind of an ongoing thing. I hope that answered the question.
Yes, very well. And there's tons of people that are just saying thank you so much, and they love the, you know, the more like practical way you put that, because it's honestly true. And they also love the plastic and glass ball analogy. So
Someone asked what lipstick you were wearing. If you want to plug your lipstick real quick,
Yes,
please.
please pause. For her social media, we actually did not find Dr. Snow through social media.
We can ask her.
Okay, so this is Kat Von D.
Yes.
And the color is Bauhaus. This was actually the lipstick I wore when I was doing my residency interviews because I really don't wear makeup that often. So it's lasted a really long time. I should probably throw it out, knowing what we know about bacteria.
We're asking just real quick, because we didn't find you through social media. And so do you have like a professional one or is that more just, no? Okay. Then we will not plug any social medias here. They're just, people just wanted to like, they just want to keep hearing from you. So you
Well,
have, you
I
have
can do
some
more. We can talk more anytime.
you have
Yeah,
some
absolutely.
social media, I guess, I don't know, they want to like make you a social media. So there's many people in the comments who want to hear more from you.
You're very
Also, they said that Kat Von D should sponsor you, so there you go.
I'm obsessed with this lipstick. I mean, I only wear it like 2 times a year, but still, it lasts. You can see there's only like minimal stuff on my mimosa glass.
Well, thank you so much. We appreciate you being here, and we hope to have you again very soon to talk more and delve more into some other topics. But while we still have you, I guess we have one last question. Like, do you have any advice for us as pre-med students and, you know, this lovely little COVID world that we're still in for I don't know how much longer?
Yeah. Basically, find what makes you weird. Embrace your inner weirdo because, you know, and we were talking about this kind of before this got started, you know, there's a lot of pressure to do this certain path and everybody is kind of the same. So I really want you to, you know, whenever you're doing your med school interviews, whenever you're doing your like personal statement, try to find something that is what makes you unique and different, because that was something that I think has made me be a better doctor is the fact that, you know, I majored in art. Like I would go to my honors organic chemistry class and then we would go to art history and sit in a dark room and drink wine and argue if it was a penis or not in the abstract art. Spoiler, it's always a penis. So, and then just having that experience, you know, I worked retail, I worked food, I did all kinds of weird jobs. I was a party model where there would be these themed parties and I would dress up. One time I was like a bearded lady at a circus party. It was really fun. But just do sort of like different things and then embrace what makes you weird and different, because that is how people will relate to you. So a criticism I've gotten a fair amount is that I don't have a work persona. This is what I am all the time. And sometimes people are like, you know, you have to have your professional blah, 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 blah. And you know, if that works for you, that's fine. Some people need those boundaries and those walls. But for me, that's not how I am. I just am myself, for better or for worse, most of the time for worse. So just embrace that. Whatever makes you you, what makes you different. Do you knit? Do you like to run? Are you into gardening? Are you really into cooking? Do you have a phenomenal shoe collection? If so, I want to see it. That sort of thing. You know, what about you makes you different and makes you weird? Because I think we need more weird people in medicine.
Thank you. Someone said they're literally sitting here knitting as you're talking about it. So, oh my gosh, that's awesome.
My goal is ultimately to knit an ugly sweater like Molly Weasley for my husband every year. And so
Obsessed.
that my stitches are not really very good, but I'm learning. I'm working on it. I joined a local knitting group here, and it's mostly older women, and I love them. They're amazing. It's like having like 20 grandmas.
That is so awesome. We are, like we said, we're obsessed with you. We love you. Thank you so much for joining us. And
Thank you.
for everyone, we'll definitely have you back next semester when we